invite our speaker today, Dr. Alga Jalit Samapta, to the online stage. Hello, good morning.
Morning, Madel. How are you, Madel, in Japan?
Yeah, it's like medicine for me because I've so missed Indonesian hospital disaster activities. Thank you, invite me as moderator today. So please, you will be a present about the regulation update regarding safe hospital in Indonesia, and also speak about hospital risk management today, right?
Okay. Okay,
Very
thank you, Madel.
interesting. Please.
Okay. Okay, thank you, Madel, for giving us to opportunity deliberate presentation of importance implementing safe hospitals. But before starting, I follow Mr. Jaya before. Honorable for Mr. Jaya, allow me to say pantun also, like my boss, Mr. Jaya. So please, audience, say cakep ya. Let's visit to Kebumen
Cakep.
and have lunch sate ambal. You know sate ambal?
Cakep.
Okay. Ladies and gentlemen, let we learn about safe hospital.
Cakep. Cakep, it means nice, yeah. Okay.
Okay. Okay. Firstly, I would like to thank to our God Allah Ta'ala and salawat to Muhammad Sallallahu Alaihi Wasallam. Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Alhamdulillah, in this morning, I, Dr. Ghazali from Health Crisis Center, present about enhancing safe hospital disaster risk management strategies in Indonesia. Okay, next slide, please. We look this picture, this situational analysis. We know that Indonesia is an archipelago and crossed by a ring of fire, full active mountains and high rain density. And in this picture also, we look red and yellow. Almost them Indonesia don't have a place safe for disaster. Currently, there is some disasters such as now in eruption Mount Lewatobi Laki-Laki at East Nusa Tenggara, and also floods now in Sukabumi and Cianjur. And also there's several incidents of malaria endemic, such as in South Nias and Riau. We call Indragiri Hilir. And also based on data in IRBI, we call Indonesia Disaster Risk Index 2023 years. The most deathful disaster was 2031 in Cyclone Seroja in East Nusa Tenggara, and also in 2022, followed by earthquake at Mamuju. So we look this data, Indonesia mostly suffer in after disaster. So we can see in this picture, there's full red and yellow also, which means that there is no place in Indonesia free from disaster. Even that disaster, non-natural disaster and social disaster. So, hey guys, hospital, do we prepare for this? Okay, this is the answer for you all, guys. Okay, next slide. So our background make this program with UGM, Gajah Mada University. Its background from the Safe Hospital program is third pillar, we call health transformation by MOH, which is how to create a resilient health system in mitigation, preparing, and responding to health crisis, even that in national and international levels. Indonesia is vulnerable to disaster, therefore, this time for hospital to be active on reducing mortality and morbidity. Please, hospital, do this. In regulation number 17, 2023 about health, every health facility is required to provide health services in times of disaster to save lives, prevent further disability, and the best interest for the patient. Every hospital is required to have disaster management system. Also, international commitments, Sendai Framework, and Asian Leaders Declaration on Disaster Health Management, which is country will promote and implement sub-hospital program in their country. So this is our background. Next slide. And today, the Ministry of Health and Faculty of Medicine of Gadjah Mada University are working together to implement a safe hospital program, which is Faculty of Medicine of Gadjah Mada University as the Secretariat of AIDHM. We call Asian Institute for Disaster Health Management. Thank you, Madel and friends. For this impact of hospital, disaster has two impact, which is direct impact. For example, is hospital affected by eruption of Mount Merapi. Remember, the beginning of 2000 years, Kaliurang and hospital in Muntilan affected by eruption of Mount Merapi. And after that, earthquake. Remember, we are in Lombok, East Lombok, and also North Lombok. The hospital is has disaster, which is as a result the health services experience off stop or interruption. So no more services health. After that, indirect impacts, such as incident in Kanjuruhan, we call football game or soccer game. We know at the time of trials and referral has chaos, and the time everyone was confused about how to refer the patient because there was no system at that time of the accident. On the moment of the fire at Semen Padang Hospital, West Sumatra, all ambulance headed to M. Jamil Hospital to transfer patient, even though there were still several hospitals in Padang area. There's many hospitals, but just one hospital, they refer to Mr. Jamil Hospital. So we can conclude there is the importance of the hospital management system during a disaster of health crisis. Okay, so we need a system, we need a management, we need how to out from this effect of disaster. So next slide. Okay, we call the system is safe hospital. Safe hospital is keep the services accessible and functional at maximum capacity before, during, and immediately after emergency and disaster situations. The hospital is safe place for health worker, patients, and their family, as well as for the health facility and infrastructure we need. In addition, hospital must be prepared for a variety of future risks, including those due to climate change. Yeah, WHO every time say climate change make a disaster. That we call Indonesia should be prepared for disaster in hospital. Then we know we have safe hospital now. And next slide. Okay, from this three hospital function, we should think and we have one mindset towards the importance of disaster management system in hospitals for safe and comfortable hospital for health workers, patients, and community. Hospitals and the working area. The hospital is reimbursable for providing services to community in working area. Hospital in the health system as referral center, providing specialist, subspecialist services, education, and research center involved in disease surveillance and public health data collection. And the next one, hospital in the border social system as a vital asset in disaster management and integral part of community health promotion effort on disaster risk reduction. Okay, next slide. Usually we do accreditation every 2 years, and every year we evaluate our hospital accreditation. Okay, the question is whether we have implemented a good or correct hospital disaster plan. We do. Often we don't understand how to make HDP or hospital disaster plan. Even our hospital suppliers trick us by copying other hospitals. Of course, we often copying this HDP from other hospitals. So now today we learn how to make HDP or hospital disaster plan, how to do it better than before. So the second one, we are coordination, cooperation, and collaboration. What is the pentahelic elements? Pentahelic here is our cooperation between the private sector, media, NGO, mass organization, professional organization, military or police, academies, helping each other during pre-disaster times. For example, like creating emergency training, simulation, or working together during emergency response and post-disaster. For example, Indonesia cannot alone. Hospital cannot services help by himself. The hospital needs health sector, need BPPD, need Basarnas, need police, need Muhammadiyah, need MDMC, need academics like UGM or Indonesia University. Also like private sector from their money, from their CSR funding. Also like Muhammadiyah, we call MDMC for helping in the during emergency response. So how do we provide competent and trained and adequate human resource as well as structural and non-structural safe infrastructure that can function effectively in the event of disaster? And of course, adequate funding allocation, including emergency funds. This is the very important thing. Yeah. Remember, in Indonesia, when we prepare or we make a plan to make money to mitigation to preparedness, very difficult. For example, the private hospital. Hi, boss, I need money for simulation in this hospital. Maybe your boss say, oh, this wasting money, no need prepare, no need simulation. Just you found the profit help. Just look at money. Don't ask the money for preparedness and mitigation. Always like this. But after the hospital get disaster, they has losing, they has several, they have what we call they are losing money after disaster. So say your boss, hey director, hi boss, I need money for simulation, I need money for make HDP, I need money for make a simulation, or I need something do for mitigation and preparedness in our hospital. So please, audience, make this after our seminar. We can find your boss to ask this one. Also, risk assessment information system strengthening and integrate with National Health Information System, strengthening research for evidence-based decision making and effective risk communication and crisis communication. Okay, next slide, please. Okay. The role of hospital disaster management. We know disaster management have three event or three parts. The first one is pre-disaster, and the second one is during event during a disaster, and the last one is post-disaster event. And pre-disaster activity are carried out in order to reduce disaster risks. We call risk management. We should reducing hazard. We should reducing vulnerability. We should improve capacity. How to make reducing hazard? Like accident prevention, disaster management system, implementing K3 or OHS standards, Healh as bridge for safety. How to reducing vulnerability, strengthening structures, non-structural, improving environment condition, and also contribute to improving public health status and preparing adequate budgets. Again, about budgets. And the last one, how to improve capacity, establish of hospital command system for disaster, establish hospital health reserve personnel like EMT or TGC or other teams, development emergency and disaster SPO, development hospital disaster plan, prefecture, human resource training, and so on. So that's we call improve capacity. Activities during disaster are carried out in order to save lives, prevent disability, and ensure essential health services continue to run in accordance with the minimum standard of health services, including for post-disaster, the hospital must restore, disrupt, and stop services function, including post-disaster need assessment in hospital, immediately repair, improve the function of health, monitoring and supervision, and also learning the evaluation. Okay, next. Next is hospital risk management. We divide it into 4 ways: risk analysis, risk management plan, risk management implementation, and the last one, monitoring and evaluation. There are 2 ways how we analyze risk to hospitals, like HSE or Hospital Safety Index and HVA. After that, we made HDP for planning how to manage disaster in hospital. The hospital identifies the existence of potential hazard and the impact they could have on hospital services. Incident commander developed disaster management planning according to specific priority based on hazard vulnerability analysis. For risk management implementation, we need effort to prevent, manage hazard, reduce vulnerability, and increase capacity. And after disaster, we short monitoring of program implementation and review of intervention, resolve risk analysis, and MET program improvement. So where is hospital disaster plan? Disaster HDP when we made a risk management plan in hospital. Next. Okay. So what is the difference between SSI with HVA? Uh, Hospital self-index, in order to increase hospital preparedness, is facing disaster or hazards. There is an assessment that can be used, namely hospital self-index. The hospital self-index created by Pan American Health Organization in 2008 is used to measure the level of hospital safety in the face of disaster. This forms help to assess the possibility of hospital or health facility remaining operational in emergencies situation. This index we developed through a process of dialogue between experts in Latin America and the Caribbean, testing and the request 2 years by Pan America Health Organization, or we call DMAC. So what is HVA? HVA is Hazard Vulnerability Assessment, a systematic approach to identifying all possible hazards that may affect population, consequences of vulnerability relate to both impact on the population and the services demand likely created by the impact. Assess the risk associated with each hazard. A probability if disaster occurs, then consequences for the population, and study the finding to develop of priorities comparison of disaster vulnerability. And HVA can be formed at the community level or in hospitals or other healthcare facility. Because hospital and other healthcare facility have always been on the front lines of preparing and for first responding to disaster events. They are now expected to be a community organization rather than independent institution. We typically depend on hospital to treat disaster victims, provide ongoing healthcare to community, and prevent secondary disease outbreak caused by loss of infrastructure or sanitation. And HPA, a key step in emergency response to disaster, it should be able to methodically assess the level of impacts and provide background information for creating target disaster mitigation plans. Community HVAs and hospital HVAs should be designed to complement each other for disaster emergency response and rescue. So, and HSI and HVA complement each other. Remember, both assessment is complement each other. Conduct by across department team that understand how to complete and has experience in with what is being assessed. So this assessment is complement each other. Next. Disaster risk analysis method is in hospital. IC or HSI management tools used to assess hospital preparedness in facing disaster. The SSI assessment is carried out based on 4 modules, namely hazard that affect hospital safety, structural safety, non-structural safety, and the last one, emergency and disaster management. SSI consists of 4 parts, namely about the geographical location of health facility, and 2 regarding the safety elements of building structure, and the 3rd one about non-structural safety elements. The 4th one is about the functional capacity of hospitals. The checklist is used to make an initial diagnosis of safety and capacity to provide services in the event of emergency and disaster in hospital. It contains 151 items, each with 3 safety ratings, low, average, and high. The checklist is divided into 4 parts module. First module we call hazard that affect hospital safety, and the role of hospital is emergencies and disaster management. And the second module is structural safety. And third module is non-structural safety. And fourth module is emergency services and disaster management. And the right side, HVA, is used to assess hospital vulnerability to disaster origination from internal or external to the hospital. The disaster in question can be natural disaster, technological disaster, material disaster, disease disaster, or human disaster. Several toolkits have been developed to prevent HVA. One that is widely used is HVA, which is developed by Kaiser Permanente, or HVA allows for quantitative probability assessment of impact, human, property, and business. Readiness, response, and risk for different hazard categories. The level of each measure, you can see the picture, of measure is usually expressed a numerical score with 0 or none, or 1 we call low, and 2 we call medium, and 3 we call high. Each measure is ranked for separate malicious, even, and weight in final average vulnerability score. The HVR toolkit provides a common basis for sharing and comparing data and for prioritizing different hazards. HVR tool contains incident happen naturally, main technology rating, scoring of each section, 0 to 3, on vulnerability, human impact, risk of injury, death to staff or residents, property impact, risk of damage, cost to replace for the temp replacement, repair, and etc. Or time to recover. In business impact, such as manager are distracted, employee access work, customer access to facility. Do you have any agreement that will result is fine penalties, legal fees, critical supply disruption, reputation, like financial impact. That's different of HSI with the HVA, or the different hospital safety index and hazard vulnerability assessment. Next slide. Now we begin to hospital disaster plan, or HDP. HDP is a part of the hospital disaster reduction plan. HDP action plan for disaster management in hospital. The HDP is developed in disaster and part of the regional plan and aligned with the regional plans and strengthens. It is development by across department team of leaders, emergency services, housekeeping, and others. HDP planning must consider issue of gender, disability, and child protection. Next. This is around our approximate contents of outline of HDP. They have 12 outline. We began with the introduction, like background, purpose, legal basic, scope, objective. The last one, we have HDP measure and trials, monitoring and evaluation, and the last one is closing. So we have 12 chapter when we made hospital disaster plan. Next. Also, we made what we call command and coordination system, or HEOC, Health Emergencies Common System. We see the coordinator, yeah, the green one, yeah. The organization pledge should refer to existing to organization structure. The organization structure is simple, has clear change command, and can be activated at short notice. The last one, common room and emergency operation room available. We can see the right side. This is a structure of organization, yeah, in a hospital. So, where is hospital behind? Hospital is under of subcluster health services. Okay, this is command and coordination system. Next slide. So, what is even of the Ministry of Health when the hospital get corrupt or get disaster? What is event? This is our event. The first one in 2023, Healh has answered with Samsudin University and Gajah Mada University. We made program and activity related to disaster safe hospital facility. And on July 2023, regional capacity building workshop and soft hospital at Manado. And October 17, 2023, we made a pre-conference in Yogyakarta in the Asian Academic Conference of Safe Health Facility in Yogyakarta. And 26 March, we make guideline for safe hospital. And the last one we have Renstra, or we call Plan and Strategic for Ministry of Health 2025 to 2029. We have target 192. Remember, this plan for strategic, we have 192 hospital in this response, province and districts, cities that have hospital disaster plan. So all these hospital should have hospital disaster plan and also simulated. Next slide. So the role of Indonesia in ASEAN. In 2022, Indonesia has been appointed as lead country to implement the ASEAN Leaders Declaration on Disaster as Health Management. Priority 4 on disaster safe healthcare facility. Target until 2025, ASEAN Organization Seminar on Disaster Safe Health Facility at least once a year, and joint research on disaster safe health facility at least once a year. The Ministry of Health collaborated with Faculty Medicine of Gajah Mada to organize Asian scale seminars and collaborate with Medicine Faculty Samratulangi to organize joint research. And next slide. This is our safe hospital guidelines. They have 6 chapters, and we have linked this for this guideline. We have in Bahasa, and also we have English. Okay, next slide. Circulator, we have produced circulator on the implementation safe hospital guideline. The implementation of provinces level regional to promote and capacity building process, which is circulator on the implementation of safe hospital guidelines to provincial, district, city health offices, hospital leaders, heads of independent institution for hospital accreditation, and head of hospital organization. So we can see this is a circular letter from Mr. Punta, or General Secretariat Ministry of Health. Next. And also we make a video promoted on social media and direct to hospital. We have also this link YouTube. Yeah. Next slide. Also, Head Crisis Center, Mr. Jaya, projects facilitator degree, which is med facilitator network team involving HR capacity building in the hospital. The function of the degree is first one, implement and deliver the safe hospital guidelines. The second one, implementing communication and networking of safe hospital facilitator. And the last one, carry out relearning or refreshing knowledge about disaster safe hospital. Next slide. This is our mapping, team mapping, our facilitator team mapping. We have 5% in Sumatra and 15% in Jawa and 1% in Kalimantan and 9% in Sulawesi. Next slide. Next slide. Okay. So this one is Ministry of Health Strategic Plan 2025 until 2029, which is the goal output is 192 hospital industry from province cities that have hospital disaster plan and simulated, which is it begin 2025 till 2029. For next year or 2025, we have planned for 40%, which is 76 hospitals should be has HDP and simulated. Next one. So the last one, the horizontal last one, to achieve the target 2025. So we start early to make a hospital assistant in making HDP and simulation to about around 7 hospitals. One hospital in Makassar, in Tajuddin Khalid, and the second one at Muhammad Yunus Hospital in Bengkulu. And the third one is Sidoarjo, East Java. And last one, we have 4 assistant making SDP at Bandung Raya Hospital. So we can see this our picture when we made assistant making HDP, and also we have simulated. Maybe this is the last our presentation. Hello, Medal, are you still there?
Yes, of course.
Okay, I give you floor break to Miss Medal. Please, Miss Medal, thank you.
Oh, thank you very much for valuable explanation and also the update, the regulation and activities during last 2 years from Ministry of Health and then also national facilitator to improve, to enhance hospital disaster plan and also safe hospital in national and also subnational level. Thank you very much, Dr. Al-Ghazali. Now we invite our distinguished discussion today, Pak Gede Yulian Yogadita.
Hello, good morning, Miss Madel.
Hello, good morning. I heard that you are in outside in the Sulawesi province now, Pak
Yeah,
Gede.
yeah. Considering our country, Indonesian country, is quite vast and diverse. Currently, I am in the South Sulawesi province in Makassar, facilitating the tabletop exercise for the reproductive health simulation. Yeah.
Okay, so you are one of the national facilitator as well from Java province, yeah. Okay, Pak
Apparently,
Gede
yes.
Yulian Yogadita, you have 20 minutes to make a feedback or comment for the Dr. Al-Ghazali or everything. you have a concern about hospital disaster plan and also safe hospital. Time is yours.
Yeah, thank you very much, Ms. Moderator. Good morning, distinguished participants, and also our esteemed speaker from the Ministry of Health. As mentioned, that our, not our, maybe the Indonesian government already have so many efforts in reducing the risk, especially in the context of health facilities by having the regulation and also initiative in self-help facilities. They have also developed very nice guidelines, both in English and Bahasa Indonesia. And you can uh, download these documents in the slide 19, I think. And they also have already like 30 facilitators in Indonesia. Also, as I mentioned earlier, that Indonesia is like we have 13,000 islands, 38 provinces now, with 520 districts, with 30 national facilitators for self-help facilities might not adequate to translate the national program to this like thousand of health facilities, hospitals, practical hospitals, and based on the class. So basically, this self hospital initiative mostly used by the Indonesian government to endorse to fulfill the hospital accreditation. Like or not, that's what it's used for on the field in the health facility. But we want to have more adjustment and alignment with the hospital class or level. So the hospital disaster plan developed by each hospital uh, adjusted not only with the class of the hospital or the level of the hospital, also with the level of the we can see here the hazard in the respective district or province. Because in Indonesia, with this diversity, we need to prioritize, especially by the Ministry of Health. We need to prioritize whether it's zonal geographical or based on the capacity of this uh, local government. So I think this Safe Hospital initiative not only to endorse to fulfill the accreditation, but also for the sake of the community, for the beneficiary. I asked our colleagues from the Asian Institute for Disaster Health Management to share this screen because using this theory, the risk reduction theory, as mentioned by Dr. Al Ghazali from our colleagues from the Ministry of Health, in the slide number 7 about this safe hospital program components, most of the components addressing for this capacity improvement I tried to use this capacity improvement by using the 4S approach of source capacity by system, staff, structure, and staff, which mostly hospital or most health facilities consider only in structure area. I try to advocate the Gajah Mada University, the medical faculty of Gajah Mada University, try to advocate in the national level, provincial level, and subnational level, how not only focusing in the structure, but also in the system by developing the hospital disaster plan and having the staff and staff ready for the disaster. By having the safe hospitals, it's not only the civitas academy, civitas of hospital itself, but also empowering the community in the environment of the hospital, nearby hospital, how we can engage. As also Dr. Ghazali mentioned, in I think it's slide number 11 or something about the methodology of analyzing the disaster risk in the hospital by having this hazard identification, hazard prioritization, and also using the pentahelic approach, which means not only the hospital itself, not only the government, not only the HEOC or a health cluster coordination approach, but also having the academician and also NGOs on board to develop the hospital disaster plan. And also mentioned by the colleagues from the Ministry of Health that actually by having this hospital disaster plan is also integrating the system, the command system in the health facilities with the command system exist in the disaster management area, such as a local emergency medical, local emergency and disaster management office or BPBD in the province and district level, or with the health office like district health office and provincial health office that already developed their own structure of health EOC, health emergency operating center, uh, to respond when the disaster occurs. So these two systems has need to be integrated. So the capacity need to improve by having this system like PSC 119, the Public Service Center 119 as the ambulance system for pre-hospital need to be integrated with the HEOC, the Health Emergency Operation Center, within this district health office or provincial health office, with the local hospital, local health facilities. Sometimes the ambulance from the PSC 119 belongs to the hospital. So this is need to be documented in the hospital disaster plan document as well as the regional disaster plan, health disaster plan documents owned by the district health office, provincial health office, or even the national command center for the ambulance system. So you have this EOC in the regional base connected with the hospital disaster plan and connected with the so-called incident command system within the institution, within the hospital. That's how we build the operationalized hospital disaster plan. Of course, in parallel, we also need to consider regarding the structure, regarding the other medical logistics, regarding the equipment, and other, as mentioned also by our colleagues from the Ministry of Health, using the HSI or the Hospital Safety Index as a benchmark, as a parameter to ensure that our hospital, every hospital in the world, in the Southeast Asia, in Indonesia, according to the standards, according to the accreditation, and how we can communicate with and also advocate with the surveyor for this accreditation that this is important. This is a part of the critical points that they need to consider if they want to pass the hospital to some level of accreditation. So I think this is a quite interesting areas that we need to explore. It's not just like a business as usual. This is not like paperwork to fill on to get your accreditation. But the hospital needs to really consider and give their best to improve this capacity using this 4S um, search capacity by having also knowing the hazard inside and outside of the health facilities, coordinating with the coordinate with the health officers, with the district health officers, nearby health officers, provincial health office to enable more resource mobilization, effective resource mobilization. And especially, as also mentioned earlier, that the vulnerable groups need to be identified, and the service of the health service from the hospital need to be improved. So I think that's from my side, Ibu Madalina, Ms. Madalina, as moderator. So maybe we can move on to the question and answer if you allow. Thank you very much.
Thank you very much, Pak Gede Yulian Yogarita and also Dr. Olga Jali. So now time for a discussion. Actually, I have some draft question to to trigger our discussion today, but I um open for discussion from online participants, please. You can open your mic or maybe raise your hand or maybe